Okay, let's talk about one of the toughest challenges in orthopedics, the distal humerus fracture in adults. I mean, these are notorious. The complex anatomy, that thin wafer of bone, and the high risk of getting a stiff elbow, it all demands a rock-solid plan. In this explainer, we're going to build a clear framework, step by step, to help you absolutely nail this topic, both for your exams and in your practice. Right, let's just dive in. This 3D CT reconstruction shows you exactly what we're up against. Just look at that. You can see how the joint surface itself is completely shattered, and the columns of the bone are totally separated from the shaft. It's this sheer level of complexity that means you absolutely have to have a systematic approach to get a good outcome. So here's how we're going to break it all down. We're going to tackle this in 4 key parts. First up, we'll get the classification down pat. Then we'll map out the treatment algorithm, when to do what. After that, we'll get into the nitty-gritty of fixation techniques. And finally, we'll cover those important special cases. By the end of this, you'll have a solid framework you can apply to any scenario, whether it's in an exam or on the ward.
Okay, first things first, classification. Before we can even think about treatment, we have to be able to describe the injury accurately. We need to be speaking the same language. And in any trauma scenario, especially in an exam, that starts with a precise classification. It's the foundation for everything that follows.
The AO/OTA system, it can look a little intimidating at first glance, right? But it's actually incredibly logical. See, every long bone gets a number, and then each segment of that bone gets a number. So the humerus is bone 1, the distal part is segment 3. You just put them together, and you get 13. So anytime you see a 13 fracture, you know immediately we're talking about the distal humerus. It's as simple as that. Now, let's get to the letters A, B, and C. This is where it gets really important for your decision making. A type A fracture is extra-articular. It's completely outside the joint. A type B is partial articular, meaning part of the joint is broken, but there's still a connection to the shaft. And then there's type C. That's a complete articular fracture. The joint surface is totally disrupted, often in that classic Y or T pattern we see so often. That one little letter tells you so much and points you directly toward a treatment plan. All right, so once we've classified the fracture, we can start building our treatment algorithm. We really have 3 main pathways, 3 main options. We can manage it conservatively, we can fix it surgically, or we can replace the joint entirely. The real art and science here is picking the right option for the right patient with the right fracture.
Think of this table as your decision-making command center. It's really a 3-part puzzle you have to solve. First, you look at the fracture itself. Is it even possible to put it back together? Second, you look at the patient's health. Are they actually fit enough for a big operation? And third, what's their lifestyle? What do they need their elbow to do? When you line up the answers to those 3 questions, the best treatment path usually becomes pretty clear.
And let's be really clear about this. While we have 3 options, the evidence points overwhelmingly in one direction. For pretty much any displaced fracture in a patient who is medically fit, surgery is the standard of care. We know from plenty of research that trying to manage these non-operatively leads to much worse outcomes, including high rates of the bone just not healing at all. So if we've decided to fix it, the gold standard is dual plate fixation. Let me say that again, dual plate. A single plate just is not going to be strong enough. But how we position those 2 plates, well, that's a key point of debate. Let's dig into the 2 main philosophies. These images show the 2 main schools of thought perfectly. Over on the left, you've got orthogonal, or what we call 90-90 plating. See how the plates are at right angles to each other? Then on the right, you have parallel plating, with a plate on the medial side and a plate on the lateral side, about 180 degrees apart. Now, for your exam, you'll definitely want to know the theory behind these 2. The 90-90 setup creates this really rigid perpendicular frame. The parallel method is a bit different. It works more like a Roman arch, where long interlocking screws create an incredibly stable structure. Now, in the real world, the clinical outcomes are pretty similar between the 2, but understanding these biomechanical differences is absolutely crucial for a high-scoring exam answer. The parallel plating technique was really championed and perfected by the surgeons at the Mayo Clinic. They basically boiled it down to these 4 key principles you see here. The whole concept is to build a super strong, solid block of bone at the end of the humerus by cramming in as many screws as you can and having them interlock. Then you lock that entire block onto the main humeral shaft. It's a technique that's so effective it lets us fix fractures that we once thought were completely unfixable. But hey, fixing the fracture isn't always the right answer. A good surgeon knows when to pivot to a different plan. So let's talk about the important alternatives for those times when an open reduction and internal fixation just isn't the best option. For some patients, doing a total elbow replacement right from the start can be a much better and faster path to a painless working elbow. Your classic candidate for this is an older patient, usually over 65, who has really poor bone quality from osteoporosis and a fracture that's in so many little pieces that you just can't reliably put it back together. And if they already had bad arthritis in that elbow to begin with, well, that's another huge check in the box for replacement. This right here is a killer statistic for your exams, and it comes from a really important study. It found that 1 in 4 elderly patients who were booked for a fracture fixation actually ended up getting an elbow replacement instead. Why? Because once the surgeon got in there and saw the bone, they realized there was just no way to get a stable fixation. This is such a critical lesson. You always have to be prepared to change your plan in the operating room. And finally, let's talk about the bag of bones approach. Now, it's so important to understand that this is not a failure of treatment. It's a compassionate, pragmatic choice for a very specific group of patients. For someone who is just too sick for surgery or has advanced dementia, the risks of a big operation simply outweigh any potential benefit. Here, the goal isn't a perfect-looking X-ray. The goal is a comfortable, functional arm, even if that means accepting that the bone won't heal in a perfect position.
So what's the big takeaway here? We have a really solid, evidence-based algorithm for these fractures today. But things are always changing, aren't they? Our plates, our screws, our techniques, they're getting better all the time. And they're allowing us to fix fractures that even 5 or 10 years ago, we might have replaced. This brings up a really interesting question for the future. As our ability to fix these injuries improves, are we going to see the indications for replacement or conservative care get smaller and smaller? It's definitely something to think about.